Good morning. I'd like to call to order this meeting of the Health and Human Services Finance and Policy Committee. It is Tuesday, March 3rd, 2026, and we do have a quorum present. Today we are going to have presentations from the agencies related to the February forecast overview. And we are going to start this morning with Department of Children, Youth and Families. And if Ashley Reisenauer, if you could come forward. Welcome to the committee, and if you get your slides, I guess, so they display for us. There we go. Okay, thank you. And if you could state your name for the record and begin your presentation.
Good morning. I'm Ashley Reisenauer. I'm the Chief Financial Officer for the Department of Children, Youth and Families. Today we'll be giving a presentation on forecasted programs operated by DCYF. Since the agency hasn't presented an overview of changes in the November forecast, I'll briefly go over forecast changes from November. However, most of the presentation will focus on current spending trends in the current February forecast. The Department of Children, Youth and Families operates 5 forecasted programs. I'll talk more about each of the 5 programs in the following slides, but they're state entitlement programs in which spending is based on state statute determining eligibility and benefit levels. Spending projections are updated twice per year in the November and February forecasts, and appropriations are based on those projections. The changes in the November forecast are compared to projections from the end of session. Those end of sessions projections incorporate any legislative changes from 2025. So the big factors that impact the November forecast are really updated data on actual spending and enrollment, and then updated information about policy changes and implementation. The changes in general fund spending across DCYF forecast programs was relatively small. In the 2026 biennium, there was a decrease of $20.5 million, or 2.6%, and in the 28-29 biennium, an increase of $7.8 million, or 0.8%. The changes are the result of 3 primary drivers. One, in the MFIP program, a greater share of people projected to receive state-funded versus federally funded food benefits, and I'll talk more about that in the February forecast. There were decreases in the Child Care Assistance Program were driven by lower than projected caseloads and higher than projected carry forward in federal funding. However, in the February forecast, that carry forward has been adjusted slightly. And then the last one, increases in the North Star Care for Children, were the result of higher than projected average payments and a shift in services that we saw from legacy programs with a local share to services like kinship assistance and adoption assistance that have a higher relative state share. So that's a very high level overview of November, but we wanted to be sure that you had a base to provide a starting spot to talk about changes in the February forecast. More information is always available out on our website. So that brings us to the February forecast and trends in the current forecast. This slide shows the projected state general fund spending for each of the programs and the changes in that spending since the November forecast. In the February forecast, spending decreased by $37.9 million across the entire forecast horizon. Like the November forecast, the change in general fund spending across all these programs is less than 3% in each biennium. So the net change in the 26-27 biennium is a decrease of $14.1 million, or 1.9%. And the net change in the 28-29 biennium is a decrease of $23.8 million, or 2.5%. The first program we'll talk through is the Minnesota Family Investment Program, or MFIP, which provides cash and food assistance for low-income families with children. It serves an average of 63,000 people each month. During the forecast horizon, state general fund spending is projected to increase from $99 million in 2026 to $132 million in 2029. Compared to the November forecast, projected general fund spending on the program is $16.8 million, or 7.3% lower in the 26-27 biennium, and $9.3 million, or 3.5% lower in the 28-29 biennium. The change is primarily driven by 2 things. One, the MFIP forecast accounts for a change in the mix of state versus federally funded food benefits for some people as a result of federal policy changes. The February forecast includes updated information about the implementation timeline, which will be somewhat more gradual than was assumed in the November forecast. In addition, updated data shows average monthly benefit amounts were somewhat lower than expected, so the future projections are based on just a lower base. In the second program, the Child Care Assistance Program provides assistance to MFIP families who are employed or engaged in other work activities or education as part of their MFIP employment plan. The program also provides transition year child care assistance for former MFIP families. It serves an average of 4,900 families each month. During this forecast horizon, state general fund spending is projected to increase from $74 million in state fiscal year 26 to $165 million in fiscal year 29. Compared to the November forecast, the projected general fund spending in this program is $6 million, or 3.2% higher in the 26-27 biennium, and $12.2 million lower, or 3.8% in the 28-29. The change in the first biennium is driven by an increase in the number of families expected to be served and a slight reduction in the amount of federal funding that carry forward into fiscal year 26. In the second biennium, average payments are expected to grow somewhat more slowly than previously projected, resulting in a slight decrease relative to the November forecast. Our third program, North Star Care for Children, is designed to help children who are removed from their homes and placed in foster care. It supports permanency through adoption or transfer of custody to a relative if the child cannot be safely reunified with parents. Financial support is provided to foster parents to encourage permanent placement of children in safe homes. In 2025, North Star served about 18,300 children each month. During this forecast horizon, state general fund spending for the program is projected to increase from $121 million in fiscal year 26 to $142 million in fiscal year 29. Compared to the November forecast, projected general fund spending on this program is about $1.7 million, or 0.7% lower in the 26-27 biennium, and about $1.5 million, or 0.6% higher in the 28-29 biennium. The changes in the first biennium just reflect the changes in the first biennium reflect lower than anticipated growth in participation, but those are actually partially offset in the second biennium by an increase in projected average payments and the number of children receiving kinship assistance. The Early Childhood Family Education Program is a program that transferred to DCYF from the Department of Education, and it's a community education program for children birth through kindergarten, their parents, and parents who are expecting children. This also includes the Home Visiting ECFE program, and the program is supported with a combination of population-based equalized levy programs and state general funds. During the forecast horizon, state general fund spending is projected to increase from $39 million in 2026 to $43 million in 2029. And relative to the November forecast, the spending on this program is $1.6 million, or 1.9% lower in 26-27, and $3.7 million, or about 4.2% lower in 28-29. The changes are primarily due to a reduction in the estimates of eligible children based on updated school census data. And our last program, the Early Childhood Health and Developmental Screening Program, is also one that transferred to DCYF from the Department of Education, and it helps caregivers detect factors that may impede children's learning, growth, and development. So school districts use screenings to link families with health and early learning programs and resources, things like Head Start, early childhood family education, pre-kindergarten programs, early learning scholarships, and more. So this program has been very steady at about $4 million per year, and changes are very small, less than $100,000 in each biennium. The change is just driven by slightly lower than expected participation and some, particularly of younger children, who tend to be reimbursed at a higher rate. So the forecast changes in this program, I really appreciate the opportunity to share information, and again, more information is always available out on our website. And with that, we'll take any questions.
Members, do you have any questions about this portion of the presentation? No, I guess not. All right, thank you.
Thank you.
And next, we will have Elise Bailey, Budget Director for the Department of Human Services. to the committee, and first you'll provide a forecast overview, and then we'll have MMB provide their forecast overview, and then we'll go to an update from DHS on the HR1 and federal impacts. So please state your name for the record, and you can begin.
Thank you, Chair Wickland and members of the committee. My name is Elise Bailey. I'm the Budget Director at the Department of Human Services. I am joined by my colleague, Mary Gilbertson. She is the Legislative Budget Director for the Healthcare Administration at DHS. And with that, my slide deck is a little bit more robust because we had a lot of changes in the November forecast, and we thought we would ground the committee in what those changes are and then go into the February forecast that was released on Friday. So to ground you, just a few slides on our overall budget. You'll see on this slide is the source of the funds that DHS has, or the percent of expenditures by funding source. From a federal perspective, in fiscal year 26, based on the most recent forecast, we are projected to have about $15.2 billion of expenditures through federal funds, about 10.6 through the general fund, and then the Healthcare Access Fund funds our programs by about 1.3 billion, and a few other sources as well. So how our budget is spent, about 95% of our budget is spent on forecasted programs that we'll be talking about today in our forecast presentation. This includes medical assistance, Minnesota Care, the Behavioral Health Fund, Minnesota Supplemental Aid, general assistance and housing support. About 3% of our budget is now spent on grants, and 2% of our budget is spent on operations. So this includes all of the staff that we have at DHS, along with all of the funding for our systems. I would note that we can't transfer between these accounts, and so the admin is in its own account, and the forecasted program spending is in another account. And that's important to kind of note as we see trends go up. The administrative costs to facilitate administration of the programs do not. So I wanted to note that from the onset. So this slide just shows the history of the medical assistance program and the growth over time since 2020 as of the current forecast, and by the federal and state shares. Where Medicaid is also funded through a little bit of the Healthcare Access Fund, and a few specific populations and services also have a county share or local share. The next slide goes over the enrollment over time. So you'll see the peak in the pandemic in fiscal year 23, where we had between 1.3 and 1.4 million people receiving medical assistance. And then we did the unwinding process, and it's now somewhat normalized at around 1.2 million people receiving their health care through Medicaid. And then lastly, this is a slide just showing our other forecasted programs by funding source with all funds. So Minnesota Care, we receive a lot of federal funding to run that program through our BHP funding, and I'll go over that a little bit later. The Behavioral Health Fund funds services for mental health and substance use disorder. We also have a significant amount of federal funds through that program. Housing support is a forecasted program that is state-only, as well as Minnesota Supplemental Aid and General Assistance. And then lastly, alternative care has about an even split. So going over the November forecast. So to ground us, what the forecast is showing, it's measuring the difference between what occurred at the end of session last year. So it was the February forecast of 2025, plus all of the items that the legislature passed into law. And then we update those trends based on updated claims, implementation changes we may have had, and federal impacts to our programs. The November forecast was one of the biggest forecasts, I think, that I've seen in my time at DHS. From the general fund perspective, in fiscal year 26-27, Our forecasted expenditures went up by about $1.4 billion, or 7.6%. And in the tails, it was about 6.3%, or $1.3 billion. The Healthcare Access Fund, while a smaller number, actually went up by a larger percentage, about 11.5% in this biennium and 19.2% in the tails. So going into a few of the major trends in the November forecast, the biggest change that accounts for about 56% of those big numbers on the previous screen was the managed care rate adjustments. So around 80% of our basic care services under medical assistance is paid through managed care organizations. And with that, we are required by the federal government to contract with an actuary that certifies that the rates are actuarially sound. To do that, they pull the data on what the MCO plans actually experienced in terms of costs and utilization, and then they set what the rates will be. In November, we updated the forecast to account for 2 interim rate adjustments that we did last year to ensure that the rates were actuarially sound. And on average, it was about a 16% increase. This rate growth isn't isolated to MA. We saw it all over the place in the health insurance market. For example, Commerce was seeing an average of 22% in marketplace plans. The state insurance program, CGIP, saw an average of 17%. And we saw other states experience the same need to update their rates in an interim basis as well. Going kind of deeper on what we saw and why the increase was so significant, the actuaries saw that about 3/4 of this increase was due to increased utilization, and about 1/4 was due to the actual cost of the services. One notable exception was that pharmacy the cost of the drugs was the primary growth. Looking at all the services, we saw growth significantly across all of our services, but the highest was among those claims that we pay the highest volume, such as pharmacy, outpatient, hospital, and professional services. We think this change is likely due to the health insurance market normalizing after the pandemic, where we had declining average costs during that time. And now we're, a few years out, and we're seeing new higher post-pandemic utilization of healthcare in general. While it was an average of around 16%, it varied by population. So in Medicaid, for older adults, it was up about 12.5%. People with disabilities was about 13.5%. Adults without children was up about 28%, and families with kids was about 8%. A few other trends, each of these on the screen accounted for about 14% of the change in our forecast. One was we also saw increases in our fee-for-service average payments, where the previous slide was around the services we pay for through managed care. This is around the services we're paying for through fee-for-service. And as you can see, the older adults and people with disabilities was around 3% increase, adults without kids was around 4%, and families with children, which is the biggest population that we serve, is around 1%. We also saw growth in the number of people we were serving. The last forecast that we had out February of last year, we still weren't normalized after doing the unwinding project and assessing how many people would remain on the program after the pandemic. So we consider this 1 year post-unwinding and reflects updated enrollment. With that, we saw higher enrollment for people with disabilities and families with kids, but lower enrollment for older adults and adults without children. The November forecast also acknowledged some state budget impacts as a result of HR 1. And I'll go into these in depth later today, but in general, the changes that were in the forecast were related to retroactive coverage. So HR 1 required that instead of allowing states to go back 3 months of retroactive coverage, it only allowed states to go back 1 month for adults without children and 2 months for all other populations. The cost in the forecast results in the fact that Minnesota state law allows retroactive coverage back to 3 months, and so those incremental months would be paid through for all state funds. Another provision in H.R. 1 limited the access to medical assistance for people who are lawful immigrant statuses. It narrowed the scope, and I'll go into this in much detail later, but the November forecast assumes then that we would have reduced spending in the general fund, but a corresponding increase in the healthcare access fund as those populations would be able to access Minnesota Care. Another impact was the federal match, emergency medical assistance. Previously, we were allowed to pull down a federal match of around 90% for the adults without children category, and the H.R. 1 lowered that to our general FMAP percentage, which is around 50%. That just results in the state paying more for the same services. I would note that there are several provisions of H.R. 1 that are not in the forecast, and those are because they need state law changes to effectuate those changes. And most notably, those include work requirements and cost-sharing requirements for adults without kids. Another item in the November forecast was a change to our general federal matching rate. This is something that CMS does every year where they assess what the state's per capita income is and compares that to the national average. And this year that resulted in our federal match changing starting October of this year to go from 50.68% to 51.36%. Essentially reducing the state share contribution to the services for most populations in the program. Okay, moving on to the Healthcare Access Fund. Before I go there, I might note there were other changes in the November forecast that I didn't include in this presentation, but I wanted to note that we also had increases to long-term care, behavioral health fund, housing support, general assistance, and Minnesota supplemental aid, but I tried to squeeze it all into this presentation, but I just wanted to note, in terms of the November forecast, we did see increases almost across the board, across all of our programs. Okay, moving into the Minnesota Care HCAF changes. The Minnesota Care program is funded through managed care payments, where we were paying a capitation payment to the managed care plan, and they're paying the claims on our behalf. As with the medical assistance program, Minnesota Care also saw an increase in those rates, and that increase was around 18%, resulting in around $555 million over the budget horizon. We also saw in the Healthcare Access Fund the change I mentioned earlier related to limiting medical assistance eligibility for certain lawful immigrant statuses. This is the impact of those populations accessing the Minnesota Care program. We also are anticipating higher BHP funding. So Minnesota Care is funded through state funds as well as some federal funds. The federal funds are based on 95% of the enrollees' estimated advanced premium tax credits if the state did not operate in a BHP. And because the market itself has seen increases, that means that the funding formula would add, additional funding to the state in terms of the BHP funding we would receive. That's around $420 million over the budget horizon. While we're seeing increases there, we're also seeing lower BHP funding for certain populations. H.R. 1 limited access to the advanced premium tax credits for all legal non-citizens with incomes under 100% who, starting January 2026, and all legal non-citizens with incomes without certain immigration statuses with income at or above 100%, starting January 2027. So that means we would have less federal funding, meaning the state would pick up the remaining of about $433 million across the budget horizon. We also saw some small changes in the Healthcare Access Fund related to case mix. We're finding that we're serving more families who have lower costs and fewer adults who have higher costs.
Can I interrupt, or
Yeah.
Senator Abler has a question?
Sure.
About this part. Senator
Well, thanks.
Abler.
Just trying to keep it minimal, but the Healthcare Access Fund is, I don't know, just kind of it's one of my favorite topics. I
It
don't know, I
is.
should get out more. But the thing about the lower BHP funding with the $433 million for the changes due to HR 1, is that because they're entitled under Minnesota law, and the Healthcare Access Fund is where that was coming from, so it's automatic, or do we have to change something about that?
Ms. Bailey.
Chair Wicklund, Senator Abler, that is correct. It is an entitlement under Minnesota state law, and so it's simply less federal funding and more state funding in terms of the services we would provide.
Well, thanks. And
Senator Abler.
why Jesse James robbed banks, because there's money there. I think the Healthcare Access Fund is buying too many things, and nothing specific about this matter, but there was a time it was designed for a purpose. I'll leave it at that. Thank you.
Thank you. Please proceed.
All right, shifting to the February forecast. So this slide goes over the key items that we have in the February forecast that was released last week. Contrary to the November forecast, the February forecast has a very small change for the expenditures in DHS's programs, less than 1% change in each biennium. And most of those changes are related to two items, with 75% of the change related to the prepayment review process. So before I go into that, the other change that was the largest change was changes in MA enrollment. When we're updating for the February forecast, we're updating for updated claims that we have paid since the data pull related to the November forecast, so a small window. But we did see an increase in enrollment for older adults, about 0.8, but that's offset by a decrease of 1% in adults without kids and 0.7% in families with children, resulting in a net reduction. And as I mentioned, the largest change in this forecast is related to the prepayment review process. So since the November forecast, DHS executed a prepayment review process for 14 high-risk services across the Medicaid program. And that process utilizes analytics to detect abnormalities in claims. And then the claims are reviewed by DHS staff to determine if those flags result in the claim not being paid, or if the flag should be cleared and the claim is clean. There's three main items in the forecast related to this process. So one is timing. This forecast updates the timing to which we will pay the claims for these 14 high-risk services that are subject to the prepayment review. This is a 2-week delay where on the previous forecast, we assumed that they would be paid in one warrant cycle, and in this forecast, we are assuming that those claims would be paid the next warrant cycle, the next 2-week warrant cycle. So it results in a one-time reduction of $53 million in this biennium because it shifts the payment of those claims into the next fiscal year. The second item is related to denials. So for the first warrant cycle in February, we found that about 0.2% of the claims resulted in denials. Therefore, this forecast assumes that because we're doing this prepayment review ongoing, that we would see a similar denial rate going forward. This is a small change of about $5 million in the current biennium and $6 million reduction in the tails. And then lastly, we did see, looking at the amount of claims that were billed to the state during the prepayment review process, that we saw fewer claims submitted by providers within these 14 services, resulting in about 4% less spending for these services. We assume in this forecast that that will be ongoing since the prepayment review process is ongoing. And that results in about $75 million in savings in this biennium and about $99 million in the tails.
Senator, this is did you have a question on this slide?
Yes.
Okay, Senator Abler.
Well, and I know we'll talk about this
Yeah.
more, but just since we're doing the math today. So in the other committee, we talked about that there was, I don't know, 70 out of whatever claims. So the point on the denial part, the 0.2%, I understood that we're going to be adding more and more analytics to that, but do they think that's going to give nothing new, or is the 0.2% more than what it's been, and they think it's going to top out at that? Do you know?
Ms. Bailey?
Chair Wicklund, Senator Abler, that's a really great question. We do anticipate the prepayment model maturing over time and adding analytics and basically having a machine learning type process where the model learns as we undergo the process. For this forecast, because it was so new, it would be hard to anticipate anything different than what we experienced in the first round. It could be that we see more denials, but for this forecast, we were pretty conservative in terms of going off of the math that we see at the time.
Well, thanks, Madam Chair.
Senator Abler?
Just, on the next thing, the cost avoidance part, this 4% spending, less people applying, how do you know that's going to stay? So compared to October and then compared to December, there were 4% less in the same cluster of services. Is that what that means?
Ms. Bailey?
Chair Wicklund, Senator Abler, how we did this analysis is we looked at each week of claims being submitted, and we saw a consistent reduction over the time period of doing the prepayment review of around 4%, like I said. And we anticipate that that is to continue. We do know from other experiences of other states that that is something that is seen when you have a process where you're looking in depth on claims, that providers who may have billed inaccurately in the past are, they know they're under the microscope. And this is a consistent finding from other states that they experience something like this. But for the numbers that we have in the forecast, we did a very deep review of what exactly we're seeing in terms of volume of claims for these services compared to what we experienced prior.
And just finally,
Senator
Madam Chair,
Abler.
thank you. And so I consider this to be your best estimate, which is what a forecast is. And I hope that you'll use that same flexibility on best estimate for things that are going to save money as we try to balance our way out of the budget troubles. Well, actually, you understand my point. We've discussed this many times. But there's some things we know are going to save money that we're not given credit for. You're able to take credit for this because you're writing the numbers down. So I hope that your forecasters will use that same view as we bring forward ideas. Thank you. You'd miss me.
Go ahead, Ms. Bailey.
So some other changes, they're smaller in the forecast. One item is the nursing facility surcharge changes due to HR 1. So last session, the legislature authorized an increase in the surcharge applied to nursing homes and a corresponding rate increase for those nursing homes. Since then, HR 1 passed and will not allow this increase beyond the October of 2026. So in this forecast, we are assuming on the expenditure side, a reduction in rates compared to what we had previously projected, which was an ongoing rate increase. And on the revenue side, we are, it's a cost because we assumed previously that we would draw down the federal funds as a result of the increased surcharge. And that's about $44 million in this biennium and $118 million in the second. I would note that isn't on my summary slide because it exists on the revenue side of the forecast that we don't typically go into. Another item is around retroactive eligibility. This is another HR 1 item. In November, we had estimated what the total impact would be of maintaining the 3 months retroactive coverage at the state level. This forecast, we're just updating our assumptions based on more recent data. The previous forecast, we used the most recent closed period, which also had unwinding impacts in it. And when we updated our data, found that, well, during the unwinding, people were dropping off and then coming back on, and there was a higher level of retroactive coverage due to those volatile impacts of the unwinding period. So we've updated it based on updated data. And then housing support, we're seeing that we're serving more people, but lower payments, resulting in a small net increase. In terms of the Minnesota Care Healthcare Access Fund changes in this forecast, it's a very small impacts. We are seeing the average payments go up just slightly, and this is due to a state-funded elderly population that we serve on Minnesota Care, and we're just increasing the cap payment assumptions due to the case mix being a bit higher. We're essentially serving people with higher acuity. The other notable item is that the federal BHP funding formula, CMS does a reconciliation after the fact, and they found back in 2019 there was an error in their calculation, and it resulted in a one-time payment to the state of about $11 million. Lastly, I think this is my last slide on the forecast. I wanted to note some things that are notable on what is not in the forecast. Some HR1 requirements are not in the forecast, and I'll go over that a bit later today and notate where that is, but we only included HR1 changes that we could implement without a change to state law. So anything that required a change in order for us to effectuate is not in the forecast. It would need to be booked, or if it was a savings, saved in a bill that the legislature passes. What's also not in the forecast is the notice that the federal government sent to the state to withhold $515 million per quarter from the state. And that is not in the forecast. That's currently pending administrative hearing. Lastly, DHS got notice last week of a deferral of $259 million of claims that were paid in a previous quarter. This also is not in the forecast because there is a long process that the state will undertake with CMS in terms of the deferral and what a final resolution would be on that. And that is it.
Members, any other questions about this part of the presentation? As I mentioned, we're going to go to MMB next, and then we'll come back to the HR1 overview. Seeing no other questions?
Thanks.
Yeah, thank you. Welcome to the committee, and once you have your presentation up, please state your name for the record and you can begin.
Thank you, Chair Wicklund, members of the committee. My name is Josh Reason. I'm a Director of Budget Policy and Analysis at Minnesota Management and Budget. I was asked to provide an update on the Healthcare Access Fund forecast for November and February. In order to contextualize some of the points we'll discuss later in the presentation, I want to cover some basic details that may be relevant to the slides as it relates to the Access Fund. Major revenues into the Access Fund are the 1.8% provider tax and the 1% gross premium tax. Additional revenues are investment earnings and Minnesota Care premiums, which are dedicated to the program. This is relevant as we talk about sort of changes in revenues later in the presentation. The largest expenditure in the Access Fund is a share of medical assistance claims, which is determined by the legislature and does not change with the forecast. The state share of Minnesota Care is the second largest, and agency administration grants are also paid from the Access Forecast changes occur in the Access Fund with changes in the Minnesota Care Program, updated tax actuals and forecasts, and the inclusions of actual expenditures each November forecast as we recognize the close of the prior state fiscal year. So if we can sort of go to the next slide. At sort of a high level, the November 2025 forecast saw a projected negative balance of $28 million at the end of the current biennium, down from $20 million at the end of the 2025 legislative session. This negative balance was created by expenditure growth exceeding revenue growth. I will discuss more in the succeeding slides, but state and federal factors in growth result in expenditures outgrowing revenue. In the FY 28-29 biennium, the balance was a negative $362 million, down from a positive balance of $27 million at the end of the 2025 session. The same factors to the current biennium drive sort of the negative balance. I think understanding where we end in the February forecast, you need to have a grounding of what happened sort of in November. So we'll spend a fair amount of time talking about sort of those assumptions. So to spend a little bit more time explaining the change in November, to start the FY 26-27 biennium, the beginning balance in the Access Fund was $578 million, up $96 million from the end of the 2025 session. This higher balance is explained by a couple of factors. First, stronger actual provider tax collections, $91 million above forecast in fiscal year 2025, increased the available balance to carry into the current biennium. This was partially offset by lower gross premium tax sort of collections of around $30 million. Additionally, state agencies carried forward $13 million in appropriations from fiscal year 2025 to 2026, which, while it increases the balance at the start of the biennium, is also expenditures factored into the third line on the slide that we are projecting. So it has no net impact on the bottom line of the fund. In the current biennium, total revenues were expected to be $2.291 billion, an increase of $130 million from the end of session. This is primarily explained by stronger provider tax collections, which were $169 million higher than the end of session in this biennium. This growth is explained by stronger fiscal year 2025 collections, which are primarily attributed to stronger growth in health spending. This was partially offset by lower premium surcharge collections of $58 million. 2025 actuals update the base for tax collections, and the rate of growth remains similar across the forecast horizon. Investment incomes were also $19 million above the end of session as a result of higher initial balances in the fund and higher actuals in the first months of fiscal year 2026. Total expenditures were $2.9 billion, up $294 million, from the end of session. This was primarily explained by increased cost in Minnesota Care, which was discussed by Director Bailey and some of those factors that she just discussed. At the end of fiscal year 26 and 27, moving into the 28-29 biennium, the Access Fund in November was projected to begin with a negative balance of $48 million, down $68 from the end of session. Revenues were $85 million more than the end of session, while the same trends in tax collections sort of apply, with provider tax revenue up, offset by lower growth in the gross premium tax. The revenue growth, you may notice, is smaller in the 28-29 biennium. This is primarily attributed to investment income, which, while the balance was higher in the current biennium, because of the negative balance, it is actually below forecast. So that sort of explains why the growth was lower in the out biennium. Additionally, total expenditures were $2.799 billion, up $407 million, explained by growth in Minnesota Care, as noted by Director Bailey's presentation earlier, leaving us with an ending balance in November of $362 million. The next slide sort of just summarizes, again, sort of major drivers of change in the Access Fund. We've spent some time talking about it. So the first two are sources of increased sort of expenditure, the HR1 impacts, the managed care rate changes. And just going to cover this briefly, the additional BHP funding on net reduces state expenditures, and the stronger provider tax collections result in a higher sort of revenue and available balance in the fund.
Mr. Reason, I'm going to interrupt. Senator Abler, did you have a question about a previous slide?
Going back a little bit, I really appreciate this, and I'm not sure how the viewers at home are enjoying this particular discussion, but this is actually really important. It's just really a core part of how we finance our healthcare. And Madam Chair, I think in a way it's actually become too core a part. It used to fund Minnesota Care, and now it buys everything, and apparently we bought too many things out of it. And so if you look at the bottom line, so the net deficit is $259 million that we have to find a way to somehow deal with sooner or later, right? So in this biennium, there's a surplus, so we don't have to do anything. If we do nothing, we're going to wind up owing $250 million. Is that basically your message?
Mr. Reason?
Apologies. Chair Wicklund, Senator Abler, when you look to the February forecast, that's right. The negative balance in fiscal year 28-29 is $260 million. That is something that we'll have more forecasts. So obviously in November and next February, we'll have better projections of 28 and 29. But if nothing else changes, yes, there's $260 million deficit in the fund to address in 28 and 29.
All right.
Senator Abler?
And that's the detail sheet that people are following at home. But no, and that all lands on this committee, I think, right, pretty much.
Yes.
Welcome to the chairmanship, Madam Chair. Thank you.
Thank you. Mr. Reason, go ahead.
Thank you. So I'd like to, on this slide, take a minute to talk a little bit more about tax revenue. In this chart, the solid lines represent the November forecast, the dotted line the end of session forecast. As noted previously, provider tax collections were forecast to be up across the forecast horizon. This chart summarizes that change. As noted, between the gap between the solid blue line and the dotted blue line in fiscal year 2025, provider tax collections were $91 million above the end of session. These actual collections are reflected in future years, and the rate of growth from that updated base is consistent over the forecast horizon. As you can sort of see, the general sort of slope of the line is consistent between the end of session and the November forecast. It's just sort of that updated fiscal year 2025 data. A similar point to be made on the bottom between the solid green line, which is the November forecast for the gross premium tax, and the dotted lines, the roughly $30 million base is sort of reflected over the forecast horizon. The next slide, as we transition from November to February, I would like to discuss the following chart. This chart visualizes one of the drivers of increased expenditures in the Healthcare Access Fund, the need for the fund to cover a greater share of basic health program expenditures. For the BHP population, as we've discussed, we received 95% of the premium tax credits that individuals would have otherwise received, with the state making up any gaps. In previous biennia, as noted by the solid black line, federal funding covered between 94 and 99% of BHP claims. With expanded tax credits and increased cost, we're reducing the federal share, as noted by the dotted black line, which represents the end of session forecast. The impact of the changes in this forecast increases the cost the state must pick up, represented by the federal share dropping to 72%, requiring the state to sort of pick up in the solid blue line as access fund share. So transitioning sort of quickly to February, again, at sort of a high level, as we talked about briefly, the February forecast is improved news for the Healthcare Access Fund with a positive balance of $11 million, up from the negative balance we previously discussed. Those same factors contribute to, in the 28-29 biennium, the $260 million deficit we discussed. Again, the changes in the February forecast in the Access Fund are primarily explained by stronger revenue projections caused by additional months of sort of data and collection, and many of the general assumptions we talked about earlier continue, but are helpful to understand the position that the Access Fund is in. So again, sort of covering quickly here, sort of revenue expenditure changes. In the February forecast, in the current biennium, FY 26-27, total revenues are $2.323 billion, up 31 million from the end of session. This is explained by stronger provider tax collections, which are forecast to be up 33 million from the end of session as a result of stronger collections in recent months. Expenditures were 2.89 million, a decrease of 27 million from the end of session. This is explained by changes in expenditures in Minnesota Care and in technical corrections to the statement. These result in a positive balance in fiscal year 2027 of 11 million. In the 28 and 29 biennium, revenues are forecast to be 2.56 billion, an increase of 61 million. Again, this is explained by stronger actual collections, with forecast revenues up 55 million for provider tax. Total expenditures are to be 2.817 billion. As sort of DHS sort of explained, this is attributed to changes in sort of the Minnesota Care program. Similar to what we talked about moving to the next slide, with the November forecast, this sort of compares forecast to forecast. The dotted lines are the November forecast, the solid lines are the February forecast for provider tax and gross premium tax revenue. You can see here sort of the slight update to actuals results in higher collections over the course of the forecast horizon, just sort of updating the base they're in. And sort of the last sort of point as we sort of talk previously about sort of the deficit in the fund, just noting that sort of the Healthcare Access Fund retains a structural imbalance in all years and a negative balance in both years in the biennium. Traditionally, when policymakers sort of can confront challenges in any funds, they have choices between revenues and expenditure changes, but given the HR1 prohibition about provider tax increases, that constrains some of the options that policymakers may have to confront the projected deficit in the Healthcare Access Fund. Pause for any questions there may be.
Members, any questions about this presentation? Senator Liskey?
Thank you, Madam Chair. Madam Chair, going through the Healthcare Access Fund spreadsheet here on the more in-depth one, I'm reading through the MNsure, and it's got the number 2 next to it. It's going from 285 in 2025 to 709 in 2026. Is this going to continue to grow at that rate? And what are we looking for in the future?
Mr. Reason.
Madam Chair, Senator Liskey, the amount that sort of MNsure is carrying on the fund balance is an appropriation from the legislature. These are funds that MNsure were appropriated, I think, partially in the 24 session and some of that from, I think, 2021. These are sort of time-fixed, limited appropriations. They have no ongoing base. It's just funding that they have not used to this point. So the future statements will reflect the pace at which they spend, or if they don't spend, when those funds cancel. But absent sort of an additional supplemental appropriation to the legislature, MNsure doesn't have statutory access to any access fund spending.
Senator Liskey?
Thank you, Madam Chair. I'm just worrying about the growth of that. So it sounds like it doesn't grow after the 26 year based on what you're saying. And so I guess that's good to see. Obviously, there's some other pretty big gaps here that we're worried about, seeing that it ends with a 259,000 structural deficit. So that's a pretty concerning issue.
Any other questions? Senator Udke?
Thank you, Madam Chair. And just a clarity question, going back to page 4 of the slides. And it's not so much the data on the slide, but it was just a comment that was made. And the way it came out, it was, you said stronger provider tax collections. Is that in reference to just the cost of healthcare is going up, so we're collecting more tax? At first, I hear that and I'm going, we're not collecting all the provider tax. Some providers are maybe not paying. Is it just that the cost of care has gone up and we're collecting more money that way? Or do we have some provider taxes that we're not collecting, period?
Mr. Reason?
Chair Wicklund, Senator Rucky, thank you for the question. To clarify, stronger meant the amount of sort of tax the state is collecting. There's not stronger individual enforcement. It's just as a result of growth in healthcare spending, that sort of increasing the base on which individuals tax. It's not sort of reflective of any changes the Department of Revenue is making. It's just the absolute value of the tax the state is collecting.
Thank you.
Any other questions? Senator Abler?
And this is actually maybe the funnest presentation for me. I should get a life. So the gross premium tax, is that only on the for-profits?
Mr. Reason?
Chair Wicklund, Senator Abler, the disposition of gross premium taxes differ on the status of the HMO. So nonprofits pay a 1% tax in the Access Fund, for-profits pay a 2% tax in the general fund.
All right.
Senator Abler?
So at some point we have to figure our way out of this mess. And I was one that thought we should have for-profits helping us in ways that we look at. And so if we allow them to come in and do some Medicaid, which I thought was a great idea back. Governor Dayton, when he agreed to it, said, well, they act like for-profits anyway, so let's let the for-profits come. And now as we're losing like UCare and shrinking the pool of people available to serve, it just might be a thought, and actually curiously it would actually grant us some more revenue because they would pay 2%. So thank you.
Thank you. We will take that idea into consideration. No? Any other questions? Well, thank you for the presentation. I appreciate it. And now we will move back to, excuse me, the DHS HR1 overview. Welcome back to the table, and if you could state your name again for the record and begin.
Thank you, Chair Wicklund, members. I'm Elise Bailey, Budget Director at the Department of Human Services, and I'm pleased today to go over the changes that we are expecting from HR1. So HR1 was passed into law on July 4th, 2025 on the federal level. This made sweeping changes to the Medicaid program and will result in some of the largest changes the program has seen since the Affordable Care Act. Before we go into the details of it, I wanted to just simply let you know that this will be felt by all Minnesotans, not just folks that rely on Medicaid for their health insurance coverage, but it will be felt across the state by all people receiving healthcare services, as it will impact hospitals, providers, and the whole healthcare infrastructure. These changes will also impact local government, and it will result in increased complexity in terms of administering the medical assistance program. We anticipate that the changes will result in loss of healthcare coverage, increase in uncompensated care, reduce federal funding to states, and we have been working throughout the past 6 months on going over the 900-page bill and doing some careful planning around how we would implement the provisions, because it's important that we implement them on time and important that we try to mitigate any impacts to enrollees. Before I dive in, I know I already did a lot of budget stuff today, but this is a slide that just gives a snapshot of our program by eligibility category. This is as of fiscal year 26, so the current fiscal year, where we are anticipating to spend around $24 billion, 57% of which by federal funds, serving 1.2 million enrollees. I wanted to note this slide because a lot of the impacts of the HR1 changes are in the category of adults without children, and you'll see that in the fourth bar. And why that's important is because we currently get a 90% match, where the state share for services in that population is much smaller than the rest of the populations. So what do we mean by adults without kids? At each state, if they are an expansion state, has maybe defined this population differently. In Minnesota, it relates to people who are ages between 21 and 64, who don't have dependent children, who are not pregnant, and who are not receiving MA based on a disability. And then lastly, just a snapshot of what our program looks like across the state. The percent of the population by region is over 20% in each category or each region of the state, with some of the more greater Minnesota areas with a larger percentage of people. So I just wanted to give a snapshot before we dive in. Okay, so going into the specific changes related to HR1. Okay, the first one is work requirements. So HR1 requires that MA applicants and enrollees who are ages 21 to 64, who don't have kids, who are not pregnant, and who are not seeking MA eligibility based on a disability, will be subject to work or community engagement requirements if they do not meet an exemption. Only one other state has effectuated a similar provision, Georgia. And as of the end of 2024, their program found to spend more on administrative costs than the programmatic costs of implementing their work requirements program. There has been a lot of analysis on whether it was effective in terms of getting folks increasing the work experience in their economy, and they did not find that there was a higher workforce participation. They did find that implementing the work requirements was really complex, and so we're trying to take those learnings and make sure that we implement the provisions in a way that mitigates impacts to people. This provision is effective on January 1st, 2027. We are awaiting formal guidance from CMS. We have received preliminary guidance, but we do anticipate that we need additional guidance and rulemaking in order to fully effectuate this change. We also do need state law changes.
Oh, okay, I have to go, so you're gonna
Senator
have a large
Abler.
bill that we have to do to pass this all? Is that what you're about to say?
Ms. Bailey.
Chair Wicklund, Senator Abler, you can expect a governor's budget item on this, yes.
Thank you.
Okay, so in terms of an impact to Minnesota, we do anticipate a loss of coverage. In some instances, people will not be eligible because they do not meet the requirements of the work requirements. In other instances, people will not be eligible due to the administrative impacts of having to return paperwork and challenges in the administrative complexity. We do anticipate this to increase complexity in processing eligibility. So our counties and tribes do a lot of the eligibility processing for our populations. And so we are working with them in terms of trying to mitigate that impact, but we do anticipate an increase in complexity. In terms of the fiscal impact of this provision, we anticipate reduced programmatic costs for people, of course, losing coverage. On the flip side, we do anticipate increased programmatic costs for people who are seeking an exemption from the requirements. What we saw when we implemented the ACA is that adults without kids who have a disability but who do not need long-term care would enroll in the expansion population because we would get a 90% match, and there's different eligibility requirements in applying for MA. With this provision going into effect, we anticipate some people in that category would switch to a different eligibility category. And why that matters is we would get a 50% match for that population versus a 90%. We do also anticipate increased administrative costs for systems upgrades. We, of course, have to roll out how we take in documents related to work and community engagement requirements and eligibility processing costs. So diving into the details, the qualifying activities for that would meet the requirement would include employment that is not less than 80 hours a month, community service that is not less than 80 hours per month, work program participation that is not less than 80 hours a month, for example, a SNAP work program. Enrollment in an educational program that is at least half-time, and this would be defined by the institution of higher education. So this one's a little bit complex in terms of implementing because each college and higher ed organization defines what half-time is for their organization. They could also meet this through a monthly income equivalent of at least 80 hours at federal minimum wage, or $580 per month, or an average monthly income over 6 months equivalent to 80 hours at federal minimum wage. For example, seasonal workers that may work a lot in the summer, a person can meet it by looking over 6 months rather than just the last month. There are some mandatory exceptions in the law. They include people who are under the age of 19, pregnant individuals, foster youth, people who are enrolled in the parents and other caretaker relatives eligibility group, individuals eligible for a mandatory eligibility group like non-MAGI individuals, and people who were recently incarcerated in the previous 3 months. There's specifically excluded individuals beyond that. That includes American Indians, Alaska Natives, and California Indians, parents, caregivers, and guardians of dependent children who are 13 years or younger, or disabled individuals, veterans with total disability ratings, former foster care youth under the age of 26, medically frail individuals or those who have special medical needs, people who are complying with the TANF work requirements, members of a household that is in receipt of SNAP and not exempt from SNAP work requirements, people participating in a drug addiction or alcohol treatment or rehab program, inmates of public institutions, and pregnant individuals or those receiving postpartum coverage. And then there are some optional exemptions. States are allowed to offer these exemptions for people who received inpatient care at a hospital, nursing facility, or ICFDD, a person who lives in a county where there was an emergency or disaster declared by the president, a person who lives in a county that has an unemployment rate of 8% or 1.5 times the national unemployment rate. We do know as of now there are a few counties in Minnesota that would fall under. And a person who had to travel outside of the community to receive medical services to treat a serious or complex condition. Moving on to 6-month renewals. So currently, we do annual renewals for Medicaid, so every 12 months. And HR 1 changes this that we have to conduct these redeterminations every 6 months for the adult expansion group who are not American Indian or Alaska Natives. This is also effective on January 1st, 2027, and we are also awaiting formal guidance from CMS. We do need a state law change for this one as well, as currently it's done on an annual basis. And in terms of the fiscal impact, we do anticipate increased administrative costs for determining eligibility, both at the state level and particularly for our local governments who conduct eligibility on the state's behalf. The next one is retroactive Medicaid eligibility. So currently, as I mentioned earlier today, Medicaid applicants qualify for up to 3 months of retroactive coverage prior to the month of application. HR 1 changes that to limit it to 1 month for the adult expansion population and 2 months for all other groups. This is effective January 1st, 2027. And we did get an informational bulletin from CMS, but we are expecting formal guidance and additional rulemaking is expected. How this relates to Minnesota is absent a future state law change. The retroactive coverage period beyond these federal limits would be paid for with all state funds. If we did conform to the federal requirement, we would anticipate that there would be more uncompensated care for hospitals and providers, as well as medical debt for low-income Minnesotans. And then I just put the fiscal impact of paying the additional months beyond the federal share as of the February forecast. Okay, cost sharing is the next item. So cost sharing in the HR 1 requires states to impose some cost sharing to Medicaid expansion adults who have incomes over 100% of the federal poverty guideline. HR 1 did not specify what the exact amount of the cost sharing should be, but there are requirements that it cannot exceed 5% of the person's income or $35 per service. HR 1 also exempted specific services such as primary care, mental health, substance use disorder services, as well as services provided at a federally qualified health center, behavioral health clinics, and rural health clinics. And like I think almost all of the other provisions, American Indians and Alaska Natives are exempt. This one has an effective date of a bit farther out, October 1st, 2028. And we are expecting guidance from CMS, and this one would require a state law change, and frankly, some significant policy decisions on how the legislature would want to choose to set these cost-sharing requirements. The impact would be, out-of-pocket costs for enrollees. Minnesota did have cost-sharing, I think, prior to the 2023 session. And when we found then, it simply did result in uncompensated care for providers. And so there definitely is an impact to hospitals and other providers related to these cost-sharing requirements and the financial feasibility of seeking a $1 or $2 payment per service. The next change is related to access to Medicaid for legal non-citizens. So currently, legal non-citizens are eligible for Medicaid coverage. With these provisions effective October 1st, 2026, this limits this to only lawful permanent residents, Cuban or Haitian entrants, or Compact of Free Association migrants. This means that other lawful immigrant statuses will no longer be eligible for Medicaid. That includes refugees, humanitarian parolees, asylum grantees, certain abused spouses and children, and victims of human trafficking. In Minnesota, as I noted earlier, these folks would be eligible for state-funded Minnesota Care. However, I would note that the benefit set is different. For example, if somebody needed long-term care services, they would not have access to that under Minnesota Care. In terms of CMS guidance, we are awaiting further guidance and potential revised rulemaking. And in terms of a state law change needed, we would be anticipating technical changes around MA. HR 1 had significant changes related to taxes. So currently, regulations permit states to tax healthcare providers of up to 6% of taxable income. And HR 1 requires that starting October 1st, 2026, states cannot impose new or increased provider taxes that were not enacted or in effect as of July 4th, 2025. They also defined a phase down of that 6% requirement. So for Medicaid expansion states like Minnesota, this threshold will decrease by 0.5 percentage points annually starting in fiscal year 2028 and will reach 3.5% in 2032. This does not apply to nursing facilities or intermediate care facilities for people with developmental disabilities. This prohibition of the new taxes, again, was effective July 4th, and that safe harbor limit will begin to phase down in 2028. We're expecting future CMS guidance, and we do anticipate future law changes may be needed in the future. In terms of the impact to Minnesota, the legislature passed an inpatient and outpatient directed payment in 2025, and we have submitted that tax waiver to the federal government. If it's approved, we anticipate it will not be allowable after October 2026, and this will reduce expected funding to hospitals. In 2025, you also increased surcharges for nursing facilities, and I mentioned that in the forecast part of this presentation as well. We have submitted to the federal government approval of the rate increase related to that. If it is approved, we do know that it won't be allowable after October 2026, so that will impact the amount of federal funding that we receive ongoing. Additionally, once the hold harmless limit begins to drop in 2028, we may have to lower current tax rates and potentially reduce payments to hospitals that are financed by a portion of the hospital taxes. HR 1 also made changes to what's called the statistical test. So current regulations describe the statistical test when a state has taxes that says that the state cannot tax Medicaid providers at a rate that's higher than other providers. That test historically has failed to control for certain tax programs that collect Medicaid revenues disproportionately to other payers. And what HR 1 did is codify closing that, I guess, loophole, you would say, for that statistical test. The new requirement became effective with the enactment of the federal law. And what it means to Minnesota is that we would not be able to effectuate the new managed care tax that was enacted in 2025. HR 1 also made changes to state-directed payments. So state-directed payments are provider payment arrangements through managed care. And currently, Medicaid allows states to establish these payments for hospitals, nursing facilities, and academic medical centers up to the average commercial rate. HR 1 limits that. For expansion states, we are limited to paying just 100% of the Medicare rate. The new limits were effective upon enactment. However, existing approved payments and those payments currently under review by CMS must phase down the payments by 10 percentage points annually starting in 2028 until the state-directed payment is equal to the new limit. We are awaiting formal guidance from CMS. We have received preliminary guidance, and we do anticipate needing state law changes to conform to this. In terms of the impact to Minnesota, that's pending CMS review of our outstanding requests to them and actuarial analysis. As mentioned in the forecast part of the presentation, HR 1 also changed the federal matching rate for emergency medical assistance. So EMA covers emergency care services for people who meet financial and other requirements for MA, but are ineligible for coverage based on their immigration status. And currently we get a 90% match for the adults without kids population, and this change reduces it to 50%. There is no change to the services provided, but rather it's how much the federal government will pay for those services versus how much the state will pay. HR 1 also makes a change related to an error rate. So currently, Section 1903U of the Social Security Act requires a state to report the ratio of its erroneous excess payments under the state plan to its total Medicaid payments. Payments for people ineligible for the program or overpayments for eligible people in excess of the 3% error threshold during the fiscal year are considered overpayments as part of that. But currently, CMS may waive penalties where a state may demonstrate a good faith effort to correct those errors. HR 1 limited CMS's authority to waive penalties for eligibility errors in excess of this threshold, and allow CMS to apply additional penalties for other audits with findings related to errors. This is effective October 1st, 2029, and we are awaiting guidance to date. CMS is expected to publish detailed guidance on this provision in the future. In terms of the impact to Minnesota, we anticipate administrative costs to work with counties and the eligibility workers to support them in the administrative work to try to mitigate errors. And if we do exceed the 3% threshold, we would of course have programmatic impacts to the program. So that's a lot of changes, and we thought we would map out the timeline in terms of when these changes need to be put into effect. So this slide, slide 44, just goes over the timeline between the bill passing and when the last provision is in effect. All right, we'll talk briefly about our implementation efforts and how we're working with counties to roll that out. So as we sat down and defined what our strategy was in terms of pulling all these changes together and developing a roadmap for how we would implement them all, many of them being implemented at the same time, this slide just goes over what our guiding principles are. So one, we want to maintain coverage for eligible enrollees. That is obviously one big risk to multiple changes occurring at the same time, many of which have big real impacts to people receiving healthcare through MA. This is our driving principle for our work. We also want to make sure, of course, that we comply with federal and state requirements, minimize burden on the workforce. We know that our counties and our tribes already have caseloads that are really high. They're working in systems that they have to do manual workarounds. And so this is a guiding principle for us to mitigate impacts to enrollees. It means that we also need to work really lockstep with counties and tribes and try to minimize the administrative burden. We also want to simplify the process and align where possible. If we can utilize these changes to make our system work better, we would love to do that. Having robust communications with impacted communities is really important, and this is something we learned in the unwinding process where we had to re-enroll our whole population, is that making sure that we're really intentional about working with community and getting the word out is really important. And then lastly, upholding fiscal responsibility, making sure that we stay under that error threshold and we do what we can to hit the timelines. So what do we need to implement? As you could see, most of these provisions, we require legislative authority. A lot of these changes are counter to what our state law says, and so we need changes to state law along with legislative appropriations to effectuate the changes. A lot of these items, we're also awaiting guidance from CMS, and that is a challenging thing for us. At this moment in time, we have to plow ahead and implement these provisions without having the sufficient formal guidance from CMS. So that may mean, you know, our plans may need to shift and change as that is received. I'd also note the timelines are really tight. January 1st, 2027 to implement work requirements along with a lot of the other provisions is a super tight timeline, and we've been having to work on this prior to receiving any guidance from CMS in order to even remotely hit those effective dates. Implementation will require changes to multiple systems. It will mean all of our policy bulletins, working on updating our worker procedures, training with counties, solidifying our communication and outreach plans. All of those items are within our work plan to make sure that we do it as effectively as possible. This slide on slide 48 just gives a snapshot of the kinds of systems work that is required to implement all of these provisions and the timeline that we have to, the minimum timeline to implement them. So non-citizen eligibility changes, this is the first effective date that we have in terms of eligibility changes, is effective October 1st, 2026. And with that, we needed to start the work in December of 2025 to hit that timeline. The same for work reporting requirements and 6-month renewals. While those are, the effective date is January 1st, those also require us to already be immersed in doing the systems work and systems planning to effectuate it. Retroactive eligibility is also effective January 1st, 2027. If the state were to choose to conform to the federal timelines on retroactive coverage, we would need to begin the systems work in April to roll that out in time for that effective date. And then reinstating cost sharing. This one has a later effective date of October 1st, 2028. And this will really depend on what the cost sharing structure that gets passed into state law. So some engagement strategies we have. One is leveraging existing structures. So DHS has a lot of work groups and a lot of communication structures that we have to work with community. And so that's one strategy that we have, is to leverage those existing structures to support awareness and readiness while maintaining alignment with our federal implementation timelines. With that, we're also aligning our engagement to the implementation date. So some of the existing structures weren't sufficient enough. We need to do more. So we need to create targeted and meaningful engagement opportunities with our partners to share information as quickly as possible and gather feedback without having delays in implementing the provisions. Also, these are a lot of changes for people, especially enrollees on the program, and having consistent messaging on what they are and how they will impact you is really important. So we've been working across our partners to ensure that we're sharing information and engaging with them to make sure that the communication is aligned and it doesn't create more confusion and chaos in the system than what already may exist just because of the magnitude of the changes. Recipient and enrollee outreach is really important. So we are collaborating and sharing with impacted partners such as county and tribal governments. We are planning for mailings and text messages to impacted enrollees. We've set up a centralized webpage of what these changes are and the actions needed. And then are creating partner toolkits that include one-pagers and informational flyers, call center scripts, fact sheets, material for text messages and social media to just get the word out to enrollees. And I think this is my last slide, I believe, but I just couldn't end the presentation without noting there are real risks here. If we don't have a bill this year that makes state law changes and that gives appropriation to do the work, we will have challenges in complying with the timelines required by the federal government. We do know CMS is monitoring the state's implementation of these new requirements, and with all of the other financial withholds and deferrals, we know that Minnesota is under a microscope, so it's important for us to do this well and hit the timelines appropriately. We also are worried about the 3% audit threshold, because these changes are hitting the eligibility calculations and processes for our populations in multiple ways, doing 6-month renewals and doing work requirements and doing retroactive coverage, and they all hit the same kind of eligibility processes, which increases the risk for having more errors. And so that is one thing we're keeping an eye on and trying to make sure that we're, working as hard as we can to avoid hitting that 3% threshold. With that, at the end, I put some links if you are interested in. That first one is the federal changes summary. That is the landing page that I mentioned on HR1. And then some other links on Medicaid by the numbers and our reports and forecasts that you could look into for more information.
Great. Thank you very much for the comprehensive presentation. Just one small question about the risks of non-compliance. Do you have any sense of, have you gotten any feedback or definition in any of the guidance about whether there will be certain penalties for being late as opposed to, not choosing to implement at all or something like that? Is there a difference that you're seeing in terms of what the expectations are? Ms. Bailey?
Chair Wicklund, members, we have not received any guidance related to what that would look like. I think from our perspective, if we did not implement in time, we are assuming that the penalty could be the whole federal share for the expansion population. I mean, that could be the max penalty, right? And so that is something we're worried about, just given the last month of receiving notice of having a magnitude of penalties already that are quite large. That is what we're worried about if we don't hit the deadline in time. Previous administrations, we have been late, honestly, on hitting federal timelines, and we haven't seen penalties to that extent, but we are assuming the worst in this circumstance, just given our experience at this point in time.
Okay, thank you. Members, do you have questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Ms. Bailey, looking through this, obviously this is a pretty significant amount of change, and we have a very small window of time that we're here to help you with those changes. Otherwise, when we're out of session, this goes in effect on the 1st of next year, and we won't be in session until after that. Does DHS have an RFP posted to help with some of the systems work? Do we have any idea of what the cost of implementation of these things are? I would assume we're going to try and comply and get into compliance. Otherwise, like you said, we have max penalties, and those are pretty concerning. So any advice on that or where we're at?
Ms. Bailey.
Chair Wicklund, Senator, that's a great question. So a few items that come to note. In 2023, the legislature passed service delivery transformation money that, as part of the uses, and that was for systems, as part of the uses, it could be federal compliance. And so we are utilizing some of those funds to begin the systems work for these changes. Another component we have been looking at, could we secure some vendors beyond just updating our systems? Could we secure some vendors that can help with the work? And so right now we are, in our work plan, we are assuming that we will put out an RFP for a vendor to assist with the work requirements portion specifically, because that will require us to assess the entire expansion population. Who do we know within that population already is excluded based on the current info we have? That leaves a subset, and then we need to have outreach with each individual person to see if they would file for an exemption, or there are things that our data sources can't see, and to do that intricate work with those populations. We know that the counties cannot take on this expansive amount of work, and so that's something we're working on with the counties, are securing a vendor to assist us with that part of the work. I don't believe the RFP's gonna, no. We haven't put it out yet, but we can share it.
Senator Liskey? No. Any other questions, members? Senator Mann.
Thank you, Madam Chair. Thank you, Ms. Bailey, for all the work you guys are doing to try to keep up with the destruction coming from the federal government. My question is, when our hospitals start to close and we are having a hard time paying our providers, is there going to be like a committee who gets to choose who lives and who dies?
Ms. Bailey.
Chair Wicklund, Senator Mann, I think we're very concerned with the impacts of the entire infrastructure of what's happening right now.
Senator Mann.
Thank you, Madam Chair. So we're not going to get our directed payment funds from the federal government. If we do, they're going to be very short-lived. The federal government is going to take away health care from millions of people. They are taking away funding from emergency medical care for people who otherwise can't get health care. But we still have to actually provide health care to people, right? So to anyone on this committee who has ever said the words unfunded mandates, Holy buckets, which is certainly everyone on the other side of the aisle. I hope you are as angry today as you were when, say, we rolled out paid family leave, which according to this committee was like the biggest unfunded mandate in all of human history. The difference, of course, being that programs like paid leave keep families financially stable, while the destruction of our healthcare system by the federal government will do the exact opposite. So I asked this question last week, and I will ask it again, and I will ask it every single day until we have an answer, as my colleagues cheer on the actions of the federal government and say things like, I hope we are going to comply with these actions as they are destroying our healthcare system. Do we just let people die? And if so, is there a specific number that we're going to be okay with until we do something about what's happening? Thank you.
Any comments, Ms. Bailey, or I don't know that that was a question, but thank you, Senator Mann. It is really concerning that, you know, we have to do all this work to implement and spend a lot of time and money on that implementation. And the result being that fewer people will have access to this health coverage. So it's really distressing. Any other members have questions or comments? Members, this is meant to help us be grounded in what needs to happen. I think the implications of the table that you laid out with the implementation timeline, it's clear that our session work does not really line up very well with trying to help accelerate, you know, getting that work done. I think that we will have to make difficult choices, and the sooner that we can get more information about details or what you're projecting in terms of costs and, you know, the different areas where you see legislative action necessary, that will help us observe and be able to make decisions. So I really appreciate your presentation today, and if there are no other questions, members, we have no other business before us, and this meeting is adjourned.
Thanks.